Okay, Kate.
Okay, thanks, Nicole. Welcome, everybody, to the Tax 90 call today. I'm Kate Stenyam, and I'm with TASC. I'm joined today by Nicole Clement and Margot Kolseth. Just a couple updates from TASC before I turn things over to ORHP and Mike to give an update on their end. We do have the Flex conference materials that are now posted and available on the TASC website, and I can post that link. Oh, once I'm done talking here, I'll post this stuff, more information in the chat box. Just some upcoming webinars to be aware of. We have a pharmacist review webinar, and that is scheduled for Thursday, August 30th. And the purpose of that webinar is to understand why the pharmacist review of medication orders is important to the quality health outcomes, customer value, and save lives. And we'll also be discussing the purpose of the pharmacist review as it pertains specifically to Mbqip. We're looking at issues and regulations surrounding telepharmacy as well as the cost effectiveness of remote pharmacist services. And we're also going to have a financial expert on there to discuss the financial coverage of pharmacist review in critical access hospitals as far as cost reports and reimbursement goes, as well as how to use your flex funding to support the pharmacist review in your critical access hospitals. We also have a webinar coming up on Tuesday, September 4th, and that will be the introduction to the State Flex Program Evaluation Toolkit. So stay tuned to more information about that. The financial document that I know many of you are anxiously awaiting for, that is in its final phases right now, and that is the Critical Access Hospital Financial Leadership Summit Summary, and that should be finalized and sent out to all of you by the end of the month. And we will be also holding a follow-up webinar that will go along with the document and discussing the financial indicator reports. There's a Quality Virtual Knowledge Group call, and that is on Friday, August 31st, Friday, August 31st. And that is going to be focusing on challenges with Mbqip. And if you're interested in finding out more about that or joining the call, please contact Margot Kolseth. She will be leading that call. We also have a new virtual knowledge group that we're bringing together as a follow-up request from the Flex conference back in July. And that virtual knowledge group is going to be focused on balancing the Flex coordinator role. And so if any of you out there would like to join that group, I will be the one that is coordinating that, so please contact me, Kate Stenyam, and let me know if you would like to join that group. And we're looking at holding our first call probably in the first or mid part of September. So again, please contact me if you would like to join that new virtual knowledge group on balancing the Flex coordinator role. A couple other real quick things. TASC has recently published a new page on the website that's very specific for the non-compete continuation grant cycle resources. And we have resources available for each core area and specifically each objective under the core areas, including evaluation and logic models. And I will, again, I can post this link in the chat box for everybody to see because that is available now. One final thing from TASC, we have scheduled the next Flex workshop, which is, as always, will be held in Duluth, Minnesota. And that is going to be from October 29th through the 31st. And if you are interested or have anybody in your office that you think should attend, please contact Nicole Clement if you're interested in that. And again, it's in Duluth from October 29th through the 31st. That's all the updates I have from TASC right now, so I'm going to go ahead and turn things over to Mike at ORHP.
Just a reminder to please press *pound to unmute your line.
Thanks, Kate. I appreciate it. And I will be, as you can tell, there are some slide turns, and it does say Michelle. I will be Michelle for the first part of this, and then myself for the rest. But a couple things have come through. For the final IPPS rule for the Inpatient Prospective Payment System, it is currently on display at the Federal Register. What we know about it is that all hospitals will see an increase in payments of about 2.3%. Rural hospitals in general will get a 0.3%. Medicare-dependent hospitals will take a cut of 6.4%, and that's due to changes in how the DRGs are scored. So that will be a factor, and that's why they're actually seeing a reduction. there are a number of Medicare-dependent hospitals that are eligible for the sole community hospitals status, and those will be going towards the end of the year. It also finalizes the regulations that address the situation where a hospital that has never met the requirements to be classified as a sole community hospital, but was incorrectly classified as a sole community hospital. So they're basically correcting a delineation. It finalizes the parameters around hospital readmissions reduction program. It adds new quality reporting measures for the inpatient quality reporting program requirements in the inpatient value-based purchasing program. These last three things, just as a reminder, they are only relevant to small rural PPS hospitals, so they do not apply to CAUSE, but they do impact your SHIP hospitals. In the proposed segment, and this is on viewing until September 4th, is the Medicare physician fee schedule proposed rule. It adds a new payment for primary care providers to coordinate a patient's care in the 30 days following admission or discharge, and they're asking for comments from the public about how Medicare can better recognize the care transition services. Adding a series of preventive services to the list of Medicare-covered telehealth services, and then revising conditions of coverage and payment regulations to allow non-physician practitioners and limited licensed physicians to order portable X-ray within the scope of their Medicare benefits. And then it clarifies the anesthesia and related care for the purpose of the CRNA benefit mean services, including chronic pain management, if it is within CRNA's stated scope of practice. The outpatient proposed prospective payment system rule is also out there until September 4th. It increases the payment rates by 2.1% for services to Medicare beneficiaries and in hospital outpatient departments and ambulatory surgical centers beginning January 1, 2013. Rural HOPDs will see an increase in payment rates by 2.2%, and sole community hospitals will see by 2.5%. They are proposing to extend the moratorium on the direct supervision requirement related to outpatient therapeutic services for CAUSE and small rural hospitals of 100 beds or less, so they are looking for comments on that. And then extending the 2012 Medicare EHR incentive program electronic reporting pilot for eligible hospitals. They want to push it through 2013. There are no new measures proposed for the outpatient quality reporting program, but they're suspending three measures previously finalized. As required by law, outpatients hold harmless payments to sole community hospitals and rural hospitals with 100 or fewer beds is expiring December 31st, 2012. They're going to continue to apply the 7.1% payment increase for most rural sole community hospitals and procedures paid under OPPS. CMS has stated that it has observed an increase in the length of time for which patients receive observation services and is using the proposed rule to solicit public comment on potential clarifications. And last but not least, there is the supervision of outpatient therapeutic services meeting, which is going to be held August 27th through the 29th. And the information is out there on the CMS website. And if you have questions, here is the policy team. They will be glad to assist you with any and all things related to their areas of expertise, from quality to ambulance and EMS. With that, I'll transition into more of a flex or HP update. Mbqip, which we've been promising data for about a month and a half now. We are still working on the contract, but it's very, very close to being completed at this point. It's in the final reviews, so we'll be able to start ideally getting that information from Telegen, and we'll be able to start producing the reports we've been promising. Phase 2 starts September 1, and make sure that all your hospitals are reporting. They have 30 days to become compliant, and that way we can, so that they'll be ready for the next quarter. With Mbqip, we're at 11 states that are 100%. Overall, we have an 80% participation rate, and congrats to Kentucky for joining the 100% club. We still lack one state, but they are very close to joining us. It's just a matter of basically getting through the state bureaucracy, but it's something that we'll be happy to welcome them in. We had a pretty successful flex meeting in July. I want to say that this is it was an experience where I believe, and a lot of the comments I've received regarding the meeting itself is there's been a lot of good takeaways from this meeting. The format is going to be continued in this sense, except we're going to try to make it more peer-to-peer. So we are going to try to keep the topics relevant, and we are going to make adjustments because we do pay attention to all the evaluation materials, and we've had several discussions on it, and we will continue to have discussions on it. A note, there was a note within the evaluations regarding food, and unfortunately, we can't control for that because of the way things are set up in the way federal contracts are set up. We were not able to provide food, water, coffee. Those are things that did not fall within acceptable items under our contracting. Mind you, that was the rule for this year. Something may change next year. We have identified a site for next year's meeting and tentative dates of July 16th through the 17th. It will be in Bethesda at NIH, at the National Institutes of Health. They have a conference center there. With having meetings, and with federal meetings specifically, we have been instructed that we have to use federal space first before we can contact and utilize hotel space. And this year we will be having it at NIH. They have a conference center there that is available for those dates, and we hope to be able to pull something off. Plus side is there is food on site, so that is something that you'll be able to access. Again, we won't be able to provide for that, but there's at least access there for it. Reminders, FMT is about to release their quality or their financial indicators reports due out in the next week or two, so be on the lookout for that. And one last thing, for November 1st through the 20th, just mark those on on that time frame for your calendar. Your project officers will be reaching out to you and discussing your flex work plans. Consider this an early progress report because they'll be asking for any issues, any things that that hasn't been set in motion. They'll want additional details. It will be a call that will be individualized, and that way if it appears there's a need to move in a different direction, we can get a change in scope or a change in activity moving forward so that there's no time loss. We want to be as proactive as possible so that we can curb unobligated balances at the end of the year. So just be aware that your project officers will be reaching out to you from November 1st through 20th with a list of questions to go over and discuss the elements of your work plan. With that, that's the ORHP update.
Thanks so much, Mike. Does anybody have any questions? before we move forward into our webinar presentations? Okay, thanks for the update. I'm going to turn things over next to Linda Johnson. Linda is with Health Insight, and she is working with a quality improvement, Health Insight is a quality improvement organization dedicated to improving health care in New Mexico, Nevada, and Utah. She leads the Utah's Medicare patient safety team, which addresses reducing hospital-acquired infections, hospital inpatient and outpatient quality reporting and improvement, reducing pressure ulcers and restraint usage in nursing homes, and reducing adverse drug events. And she has been a healthcare quality professional for over 20 years. And with that, I will turn things over to Linda.
Thank you. Hello, everyone, and thank you for inviting me to join you on today's webinar. I titled my presentation here, Leveraging Partnerships to Succeed in National Quality Reporting Initiatives, and I left out a very important word. It should say National Quality Reporting and Improvement Initiative, because that is part of the one of the Flex Core areas. I don't think you'll be surprised to hear that where federal funds are involved, there's a strong mandate to avoid duplication of effort. So today we are going to I want to help you understand how partnerships can make everyone's life a little bit easier, and especially how you can use your quality improvement organizations to help you manage your Mbqip and QI projects. We'll also look at the public reporting at the federal level, in other words, CMS, and I'll hopefully demonstrate to you how your QIO can help you in supporting your flex hospitals. This language is taken directly from your state flex program documents, and they very clearly indicate that flex coordinators should seek other state partners, and the reason QIOs are highlighted here is because I work for one, and also indicates in your documentation that the QIOs will collaborate with states to provide technical assistance, training, and etc. The same holds true on our side. This language is taken directly out of the CMS QIO contract that is currently in force from August 1st of 2011 through July 31st of 2014, where we are required to reach out and involve other groups and organizations and collaborate to reduce and avoid, if at all possible, duplication of effort. We want to definitely connect organizations and individuals so that we can create synergy, which I think is especially important in the rural hospitals that are not as tightly linked to larger groups as the urban hospitals are. We also work to identify best practices and spread those practices among all of the hospitals. Convene leaders around an agenda that promotes learning or problem solving. And they specifically direct us to be aware of such things as the rural concerns. Now, these partnerships are going to look different in every state. I don't know what your particular state's partnership structure may look like. This is kind of a crude picture of what it looks like in Utah. We all three groups work together, the Department of Health, specifically the Bureau of Primary Care and Rural provides the Flex Coordinator, and we, Health Insight, the QIO, work together with both of those groups to make the best use of the funds, the services, and the talents that we have. So in addition to avoiding duplication, we are also able to leverage each other's strengths and areas of influence, because if you look at this little diagram, we all have influence with different people in different areas, and that's also very helpful in leveraging your resources to get this important work done. Then a little bit about what you need to know about your QIO. I'm going to focus on the QIO side of the partnership since that's my role with our Utah Flex hospitals, and I'm going to focus mostly on the work around the Mbqip. But I don't know how many of you know who your QIO is, or if you do, that's wonderful, and if you do, I hope you use them. If you don't, I hope after hearing what I tell you here in a minute that you will use them. If you don't know who they are, I'm going to tell you how you can find them. And as I said, I'm going to tell you how we can help you as Flex state coordinators to get your quality improvement core work completed. So, who is your quality improvement organization? You can find, the best way is to go to QualityNet and find the hospital reporting contact. And the next slide will show you exactly how to do that. For example, Health Insight is the QIO for New Mexico, Nevada, and Utah, and there are many multi-state QIOs. So you're going to want to get to know us and partner with us. We love critical access in rural hospitals, and I really mean that. Every QIO that I interact with, we all just really enjoy working with these people. However, we can't provide food either, so I hope that makes Mike feel better. So this is how you find your QIO if you don't know who that is. You go to qualitynet.org, and on the home page, which is public, all of these tabs here, except for the sign-in tab, are public. And the people in your critical access hospitals and small rural hospitals that are doing this quality reporting work actually delve very deeply into this website. But for right now, the most important thing is for you to find out who your contacts are. So you go to Hospital Inpatient, Hospital Quality Reporting Program, and then QIO contacts. And as you can see here, each state has 2 contacts listed, and you should be able to contact either one. And if they can't help you with your specific question, they can certainly direct you to someone in their organization who can. So why would you want to work with us? Well, first of all, we're already doing the work. We're being paid by CMS. The measures that the Flex program is using, the Mbqip measures, are the exact same measures as the inpatient and outpatient hospital quality reporting measures that CMS has us working on. We are expert in the reporting infrastructure and standards, and believe me, that is very complicated. If any of you talk to your people who are doing that work, it is not easy. We're also skilled in quality improvement and action learning, and particularly bringing together groups and individuals to build that synergy. We also have access to and access to ways of disseminating best practices. And if nothing else, we are evaluated on our ability to engage and support the rural and critical access hospitals. In fact, our measurement is to have 100% of PPS hospitals reporting and 95% of critical access hospitals reporting. For large states, the 95% is probably a little bit easier to achieve. In smaller states, that means 100% because Medicare rounds up, not down. So, for example, in Utah, we have to have all of our critical access hospitals reporting in order for us to meet our contract obligations. So here is a very, very brief comparison of the Mbqip and the CMS quality reporting measures. And Mike just mentioned the IPPS rule that was finalized just last week, becomes effective October 1st, and he gave you that link, and it does outline all of the measures. For the phase 1 and 2 of the Mbqip, you can see what your measures are there, and then for all of the hospitals that are reporting through CMS, although it's not required of the critical access hospitals that they report all of these measures. Many of them are not even applicable to them, and I discourage them from trying to do that. I encourage them to not go beyond the Mbqip measures at this point. That's enough for them to handle. But you can see there's a significantly larger number of measures on the CMS side. We work with the hospitals to get them reporting. We want to promote the QI and the transparency for consumer decision making. And if anyone thinks that the people in the rural areas are not looking at these things, they are. We've had many hospitals tell us that people have gone on Hospital Compare and looked up their local hospital. And then to work, again, educate the hospitals about submitting quality data and help them understand that data and what they can do with it. We provide assistance to the hospitals for quality improvement, not only in feedback on areas for improvement. Our analysts can drill down and say, okay, these are the hospitals that are having trouble. These are the areas that they're having trouble in. And then we work with them to improve the quality of care related to those program topics. We also do a considerable amount of education related to quality reporting, particularly involving the CMS abstraction tools, the inpatient and outpatient data warehouse, the reports that are available to them when they're working. I'll put that caveat on it. Both the inpatient and outpatient reporting requirements. There's a lot of paperwork associated with getting started, and then helping them to accurately abstract the measure information from their medical records. We also provide a lot of technical assistance and training on the CMS topics, again, improving the accuracy, timeliness, and completeness of data, and we work with them to disseminate and share their knowledge. In addition to the Mbqip support that we provide, we can also help you with what's listed in the Flex core elements under the quality improvement piece, the multi-hospital QI and patient safety projects. They list them out separately. However, these in reality are not easily separated because there is a lot of overlap. The other areas that we can help with in terms of quality improvement are reducing healthcare-associated infections and reducing hospital readmissions. Also, specifically mentioned in those core areas are having to do with the safety culture, and they mentioned team steps and the AHRQ safety culture surveys, and all of the QIOs that I know of have team steps master trainers in the organization, at least one. Many of them have two, and we have all worked with the AHRQ safety culture surveys not only in helping hospitals to administer them, but also in aggregating the data for them, providing the reports, and helping them to interpret what those reports mean, and then taking the next step and acting on them. So that, in a nutshell, a very brief nutshell, is some of the help that we can provide to the state flex coordinators on getting the critical access hospitals up and running on Mbqip and other quality improvement and or patient safety initiatives. So if you have any questions, I am here, or you also have my contact information here if you would like to ask a question. Thank you.
Thank you so much, Linda. Does anybody have any questions for Linda? Remember, press *# to speak, or you can also enter them in the chat box. Okay, not hearing any questions at this time. I think we'll move forward. I'm just going to give a brief overview of the quality reporting matrix that Nicole had sent out to all of you earlier, and we do have it posted on the TASC website as well. And just to give you a little background, the idea for developing this quality reporting matrix was initially brought to our attention by Cindy Large in Indiana, because she was feeling like her critical access hospitals, were really overwhelmed with trying to keep track of all the different quality reporting initiatives and what was what. And so we brought together a small team of, with Cindy, Larry Bronner in Pennsylvania, Carol Bischoff in Montana, and then Jessica Burkhardt with NOSOR to develop this matrix. And the matrix includes basic overview and information, as well as the measures from the National Quality Reporting Initiatives from Mbqip, the Partnership for Patients or Hospital Engagement Networks, the QIO 10th Scope of Work, as Linda was just referring to, healthcare-associated infections from the CDC, as well as the meaningful use of electronic health record, the clinical quality measures coming out of the Office of the National Coordinator. And I guess I just really want to emphasize that, this is by no means the be-all and end-all stagnant matrix of quality reporting. It's really just a starting off point meant to really be a living document for you to change and grow with it to fit your state. There was so much information, that the small team, all the meetings that we have that we could have included, but we decided we really wanted to keep it as streamlined and simple as possible so that you can really take it and manipulate it for however it best fits within your state. And the team did have some suggestions on how to use the matrix, such as using it just as a template to work with your critical access hospitals in order to track the national quality reporting measures, or to add your state-specific reporting initiatives to the matrix so that it's more of a comprehensive quality reporting document for the critical access hospitals in your state. And, or you can use it to tailor it specifically to individual critical access hospitals. And there's also a lot of things that we came up with as possible columns that you can add to the matrix depending on, what you're focusing on is, tracking the frequency of data submission, or tracking vendor use, the vendor that's used for the data submission. You could add the 10 critical aspects of hospital experience from HCAHPS, distinguish between measures that are based on data collected by the hospital or those that are kept, a column to distinguish between inpatient and outpatient quality reporting, or you could include information on the coordinating organization. So those are all just examples of things you could add, ways that you could use it, and please feel free to contact me if you have any questions about the matrix, or if you have any ideas. Again, like I said, this isn't a stagnant document. We're hoping that you could all take it and manipulate it to use it however you see fit. Or if you have suggestions on other things that would be very useful to you, in this specific area as well, please let me know. And with that, I'm going to go ahead and turn it over to our main presenter today, and that is Melissa Lynn. And Melissa is with Stroudwater Associates, and she joined Stroudwater in 2008 Her professional focus is centered on strategic and master facility planning, hospital-physician relations, and continuous process improvement of clinical and business operations. Prior to joining Stroudwater, Melissa worked with a health system and under the Division of Clinical Effectiveness. She developed quality improvement process strategies to improve clinical and administrative efficiency and coordinated system-wide initiatives dedicated to CMS core measures, the IHI initiatives, and the elimination of never events. And with that, I'm going to go ahead and turn it over to Melissa. Thank you, Melissa.
Thank you, Kate, so much for the wonderful introduction. We'll go ahead and go through these slides. This is based on my conversations with Kate, is trying to understand how you, as the flex coordinators and the directors, state directors, can really try to help your hospitals navigate through the amount of quality reporting requirements that we do have. Just based on the matrix alone, there's no shortage of the requirements that we have piling up for our hospitals, and so it's plenty enough to give your hospitals a headache, but there's definitely ways to be able to streamline that a little bit, and also make sure that you're doing it in a way that is effective and efficient for your hospitals. Certainly brings the quote to mind, water, water everywhere, not a drop to drink. Same thing here for us. It's data, data everywhere, and not a thought to think. How are we supposed to keep track of it all? And I think Kate and the team over at the National Rural Health Resource Center have done a great job of getting that committee together and pulling together the major data elements that we have into that matrix. But there's some other questions as well. How do we know that we're collecting it correctly, completed in a good manner, and also timely? And then probably the most important question, what exactly is our data telling us? What is the feedback that we're receiving from these reporting agencies that can help our hospitals become better at the care that they're providing? So ultimately what I'm here today is to talk about how lean can help to streamline quality reporting, but it's more kind of a even more base level question of how lean can improve data quality at our hospitals before we ship it off to these reporting agencies. So what is lean? The term lean was coined by some folks at MIT back in the 1980s, but the concepts were originated from Toyota Production Systems, which has really been in the manufacturing industry for several decades, probably starting in the 1950s or so. And since it's been introduced to us in healthcare in the early 2000s or so, healthcare organizations are really starting to come around to the idea of lean and how it changes the conversation around improvement, organizational culture, and of course, in our webinar here today, in terms of data. So lean provides a focused way for us to specify value by lining up all those value-creating actions in the best sequence, and then helping our hospitals to conduct those activities without interruption whenever our patients request those activities. The philosophy is really centered on a number of things. It's about defining that value in the eyes of our patients, who are our primary customers in this case, but it also looks at the opposite. What we seek in terms of value, we also want to eliminate when it comes to waste and what adds no value to our organization, but also to our patients. It also emphasizes creating flexibility and agility, because we have changing needs almost on a daily basis, it seems like, not just for the industry overall with what reform is coming through, what the final rules are that we're getting through Medicare, that we just heard the updates on, but also for our patients, what those changing needs are, what the different medical technology and science that's coming through the pike that's helping us to provide better care. How can we really look at care in a flexible way so that we can continue to change to meet those needs? And the last two, I always love to emphasize a little bit more. Lean really likes to empower our frontline folks to make sure that they're the ones that are taking on their daily work processes and trying to use these easy problem-solving tools that are based off of Lean, so that they can really start to take control of what they're doing every day and what kind of care they're providing to their patients. Lean is very much about doing more with less. We've heard that phrase over and over again in the last 2 years, doing more with less. And so it's about doing less with less human effort, less equipment, less time, even less space. And that's supposed to really push us to think and challenge ourselves on making sure that we're providing exactly what our customers want. I always want to repeat that I said less human effort and not fewer humans, because Lean philosophy in no way condones reducing staff members in order to eliminate waste and achieve value. Now, you might have noticed that in that bullet I did not mention data because it's the entire philosophy is completely driven by data. It's a fundamental skill that lays the foundation for successful improvement efforts that are powered by Lean. That means that poor data collection sets managers and their teams up for failure. But on the flip side, just like Linda was saying, good data collection makes improvement faster and easier as well. Because let's face it, we're not collecting all this data for the sake of collecting it. We're also doing it to help lead us through improvement initiatives towards better care. In our travels here at Stroudwater, for a lot of these critical access hospitals that we've worked with, we realized that some of those hospitals have been achieving leaps and bounds on the quality reporting and the initiatives that arise from those, but there are still some who are struggling to balance the regulatory requirements with some basic techniques to help them achieve those same leaps and bounds as their peers. So the next couple of slides, I hope, is going to guide your hospital constituents as we cover kind of the basics of data collection that are absolutely vital to Lean, and that should provide a solid foundation for some of the more advanced training on data analysis and Lean implementation should your hospitals wish to pursue that option. Just a quick little slide on how data drives Lean. But how can Lean improve your hospital? There's 5 main areas that Lean can impact, and just quickly, it's obviously safety, because with waste and unnecessary processes usually comes dangerous activities and unsafe processes for our patients. High quality at a low cost. That's kind of the definition of value as we continue to seek that, and that's very much about what Lean is about. But also short lead time, making sure that we're doing things in the shortest time possible and taking out any of the excess time that is wasted doing activities that don't benefit our patients. And then the last piece of what Lean can impact is high employee morale. It's going back to empowering our frontline workers to not only own the data that is surrounding them, but to also take that data and be able to improve their processes and be proud of what they do every day. The purpose of data collection is to inform, and the purpose of being informed is to have an objective reality about your business situations. So I guess a good thing to go back to your hospitals and ask them is, whether or not they're working with data or if they're actually working with information, because information is what we're really looking for. It's imperative that we're not only collecting data, but we're also manipulating it and analyzing that data. So once it turns into useful information, useful knowledge about the area that we're examining, we can be armed with facts instead of unproven theories or hunches. It really helps us to be able to answer questions about the business and clinical atmospheres that we're trying to solve here. So it's critical to collect meaningful data, and there are just far too many ways where data can be in error. It may be the wrong kind of data that for what you need, or we might be inappropriately combining data, or the way that one data collector is collecting their data is different from another individual who's doing it, which results in inconsistencies of how we're collecting it. So I'm presenting 5 major guidelines in Lean data collection that can help you to avoid these errors in your quality reporting activities. And hopefully these guidelines will help to streamline and ensure good data collection. The first one is to clarify your data collection goals. The first one is always thinking about what questions you're trying to answer. Luckily for us, nationally, statewide, we're already being given those questions. We're asking questions about healthcare-associated infections. We're asking about pneumonia, those type of issues that we deal with on a daily basis in our hospitals. But what are the data that we need to pull in order to answer those questions, and how will that data help to answer those questions, but also to meet the customer needs and improve the operations and clinical processes that occur at these hospitals. The second question I like to think about is who on the team is collecting the data. And in healthcare, hospitals are becoming used to working in silos, and that also includes the realm of process improvement and quality reporting. The burden of the data is increasingly becoming one person's task and one person alone, but guess what? One person should be owning it. Data stewardship, which is the concept of being responsible for data that's worth caring for and preserving, is making a comeback in healthcare, and for good reason. Who else would be most interested, honestly, in the results of a process than the person who performs that procedure on a daily basis? So Lean strongly advocates for the empowerment of frontline individuals to take pride in their daily work by improving it day to day. And that really should come in two ways, taking part in the data collection role, and also obviously taking part in that improvement role. It's kind of a dual process where they come hand in hand, both ensuring data quality, but also process improvement, because they're ultimately going to be responsible and accountable for the quality and simplicity of data that represents those processes. So definitely go back to your hospitals and ask them who are the ones that are really taking control of the data that flows back and forth. Now, as we clarify our data collection goals, there are two questions that will typically arise from that. What data do we need to answer those vital questions, and where can we retrieve such data? Luckily, at least in terms of the reporting requirements that we have, the metrics and their definitions are pretty much already being defined for us. So that already helps us to understand what data we need to be looking for. And luckily, many of our hospitals should be implementing some EMR or HIT solutions to meet some meaningful use guidelines. So we're starting to think about how technology is impacting our role in data collection at our hospitals. How is the related data being inputted into the system? Before, it used to be entering it onto a paper form somewhere in the chart. Now we're looking at what electronic forms that we're entering it in, and where exactly that data input goes to. How do we receive the output of it? There are also times, though, when data is not going to be readily available by EMR, and many times it's not available because there are additional data points that we need to collect that are less commonly captured in our process. For example, some of the reporting organizations are calling for us to keep track of central line associated bloodstream infection rates, but I wasn't able to pull up the additional metrics on how best to actually capture compliance of doing a good central line insertion process. So maybe we're looking at our hospitals and they want to do a better job of implementing central line bundle kits in the facilities. So how do we keep track of that compliance? We can always build metrics in that look at the individual components of that bundle to see if we're not being as compliant with the chlorhexidine component of it, or if it's the route that we're looking at for the central lines, and also just the 100% compliance, whether or not we successfully used the whole bundle or if we didn't. Those are kind of informal data points that we need to be collecting as part of our improvement process to make sure that we're actually doing the things that we wanted to accomplish as part of that journey. So even if there's no data, that means that there's no problem with that, because we always have to remember that back before we had EMR and all of these fancy data metrics, we always had to create our own data. So we can always track it on our own if necessary. We can employ some very simple tally sheets or some manual data collection forms to help streamline that process. But we really need to think about whether or not we can find this data easily through some technological means, or if we need to do it more manually, but try to drive it as simply as possible as we're collecting that data. I also want to emphasize that as part of that first guideline in data collection goals that we really need to think about making sure that the concept that we're trying to evaluate is appropriate for that particular data collection. Again, here, this is kind of just a basic piece of advice when it comes to data collection. Luckily for the quality reporting requirements that we see here, a lot of the pieces that are related to AMI or to pneumonia, there's a lot of vetting that has been done across the industry to help us make sure that we're appropriately looking at the right concepts, that we're receiving the right kind of value that comes out of that. The next piece of those guidelines that we have here that would be great to check in with your hospitals is to think about the operational definitions and procedures that go with it. Luckily for the Mbqip and P4P and all of those particular reporting requirements that they have, they're pretty specific about what they mean about door to lytic times, door to EKG times, specifically when we're supposed to start the clock and when we're supposed to stop the clock. Same thing again for making sure that we have specific prescriptions on our discharge papers. There's very, very specific ideas of how we know that data is a yes or a no in terms of compliance. And so operational definitions are very important to make sure that our data collection is consistent across the board. I always use the example of on time. When a data definition says that we need to make sure that we're doing something on time, one person might assume that that means within 5 minutes. Another person might say, oh, that means within 3 days on time when something needs to be signed or what have you. Also think about what your plan is going to be for collecting the data. What procedures are you going to use to make that collection precise and consistent? And that operational definition piece definitely plays a major role into that, but also how the data is going to be recorded. Before we IT, that meant more in terms of what assessment forms or other chart documents that we had that was going to capture that data, who was going to actually input that data, the charge nurse or some other floor nurse, who was going to be doing the chart audits themselves and actually pulling the charts down and gleaning the information that we needed out of it. Do we have that one person doing audits for all of the quality data, or do we have multiple people pulling the same charts over and over again? We definitely need to make sure that we aren't being redundant with our data collection. On the bright side, now that we have, in most hospitals at least, IT capabilities, the questions are a little bit different. Now we're thinking about what electronic forms that are going to be capturing particular pieces of data, who's going to be responsible for inputting that data, still that same question there. But the chart auditing is a little bit different now. Is it someone who's going through the system one by one through each chart, or is there a way that we can program the IT system to kind of generate a report that can pull that data for us into a usable analysis? We also have abstraction systems, abstraction tools that can help to pull data directly from our systems out to the reporting agencies that require it, just to make sure, though, that the data that they're pulling from our systems is the right data and complete in one sense. The third guideline that I always like to stress here is making sure that we're planning for data consistency and stability and making sure that the data is meaningful. Data really needs to be consistent across the board. If we had two people who we assumed were being trained the same when it came to the data collection, and yet they arrived at completely different answers at the end of their data collection, then there's something wrong with the way that we've set up the procedure for collecting that data. On the flip side, we also need to think about stability, data stability, and whether or not we're seeing fluctuations or special causes of variation in the data that we have. I know that Linda mentioned earlier with what the QIOs are capable of, and that's training for improving the accuracy, timeliness, and completeness of data. And that's kind of what I'm also emphasizing here, is that we want to make sure that the data is complete and consistent across the board. I actually came across a hospital with a fairly robust EMR system, but unfortunately the way that they had set up their systems had ultimately created 4 different diabetes worksheets in their clinics. And so when a provider had showed me how he could access one worksheet versus the other, he showed me that if he filled out the first worksheet with all the standard diabetes questions and then accidentally triggered the second diabetes worksheet into it, half of the questions would be auto-filled with the answers that he had previously given. And then for some reason, the rest of the worksheet would be completely empty because of the way that the data fields were being asked. So, for example, the one field that he showed me was the date of the most recent foot exam. That was on the first worksheet. On the second worksheet, the data field for that was actually written as most recent foot exam. And so when we're going back into our systems and trying to collect data on in an IT world, we also have to make sure that the data fields are consistent in our system, so that if we were to run a query on what percentage of our diabetes population in the community is having foot exams within the last year or so, there's not one field, but in this hospital's case, they had 3 different fields specific to trying to collect that data, which came up with a pretty incomplete way of collecting their data on their behalf. So it's very important, even in the IT world, where we like to think that there are fewer errors to incur, that we're making sure that data collection is still whole. The fourth guideline in lean data collection is, when you actually start the data collection process itself, you need to make sure that the way that you've explained the procedures to all data collectors is understood the same way across the board for all of those data collectors. And certainly practice makes perfect. We certainly could benefit more from practicing and making sure they're in the IT world, or if it's some kind of manual tally sheet system, that everyone understands how to use it before we're really starting to collect that data. But also have someone to oversee and kind of mentor people through any new data collection processes. We're constantly looking at, at minimum right now on that matrix that Kate just introduced to us, 87 different types of reporting metrics for quality, and we're constantly seeing metrics come off the list, come back on the list, depending on how well we're doing nationally to achieve certain benchmarks. And so as we start to see new metrics come on board, we also have to make sure that once those procedures are back in place, that we really do a good job of watching over each other and ensuring that we're doing data collection in the right way. Now, the last and final guideline towards good, lean data collection, if any of you on the phones have my slides printed out, if you do me a favor and cross out the word measurement and write in process, this is really that last step where we're after the data collection process, and we're now talking about the most important piece of our guidelines, which is the data analysis. This is the bridge that makes data turn into information, that valuable, useful information that can help answer our questions about whether we've succeeded in performing or whether we've lacked in one of our processes. Now, as we're looking at our data and analyzing it, we need to think about whether or not the processes are stable. The metrics are going to help us see whether or not we're consistently and stably providing the right care to our patients. Are we improving in our clinical processes? Are we still seeing increased harm to our patients? That's really where we are able to start to delineate whether or not we're doing good or bad. Just as important, are our processes consistent? Do we consistently hit our aspirin on arrival benchmarks? Compliance isn't always above 95% or exactly at 100% compliance. That may indicate inconsistency in our processes, so that what we believe to have been standardized in our hospitals may not be. And that's where that data analysis can really help us to answer those questions about whether or not we're being stable or if we're consistent in what we do every day. Now, part of data analysis is about being able to visualize what's happening in our facilities. And so I would ask you, how many of your hospitals analyze their data in this way? We see here a chart full of numbers, number of patients treated per week. When you monitor and measure a process, chances are that there are still several hospitals out there that are displaying data in the form of tables, lists of numbers. And so for this particular chart, at a moment's glance, I would ask, can you see any trends with this clinic's data presented here? Is there anything unusual happening? And if there is, most of us would have to look long and hard before they actually spotted it. On the flip side, if you were to have drawn a run chart of this data, this is what it would look like. With the run chart, if I ask again at a moment's glance, if you can see what's happening, I can already feel the nods coming through the telephone here. There's an obvious pattern occurring every 4 to 5 weeks, or more specifically, the spikes that are occurring in monthly intervals here. And if we actually dug a little bit deeper into the data that we have here, we would find out that was the spikes that were occurring at the end of the month. Data analysis is vital to making that leap from data to information, but we also have to make sure that we're able to visualize it in a way that can help us get to the answers quicker, that we can actually appropriately conclude what is happening to our processes based on the data that we have. And sometimes just basically on the way that we are displaying our data can lead us to wrong conclusions. Same thing could happen here with a bar chart. Let's look at another example. This is a number of cardiac surgeons who introduced a new protocol back in 2008 that was designed to reduce some CABG-related mortality. And so we see two bars here, one for 2008, one for 2009, and it demonstrates the mortality rate of 5% that dropped down to 4% in 2009, 20% difference, pretty significant drop, right? But do we actually celebrate this improvement? I'm sure you can guess based on the way that I'm asking that question, the answer is no. And that's because if you actually took that exact same data, and turned it into a simple run chart, we would see something completely different. It turns out that, yes, previously in 2008, for that year's average of 5%, we started an intervention in January 2009, which turned out to be one of our lowest mortality months that we had at this particular hospital. And starting with that intervention, the mortality rate started to go back up to just above the median rate for that year. And so what is the lesson here? Using tables and bar graphs when analyzing a process over time can be misleading. The way that you can analyze your data can make a major impact on whether you want to bob or weave, or if you want to call it a success or a failure. Okay. So if you haven't guessed it already, I would strongly recommend checking in with your hospitals on how they analyze their data. Because here's the scoop on run charts, or as I like to remember them, I call them the run forest run charts. A run chart is a running record of a process over time, and it's probably one of the single most important tools in performance improvement that you could have. It can be used with any process that you have and any type of data, and it's fairly easy to make. Literally, pen and pencil, paper, that's all you need. And it can assist you in identifying various trends that are occurring in our facilities. Using run charts has a multitude of benefits. They certainly can help improvement teams formulate their goals by depicting how well or how poorly a process is performing. They can certainly make some good conjectures and begin to design and experiment based off of how their process is performing. They certainly help in determining when changes are truly improvements by displaying a pattern in the data that you can immediately identify as you make changes to the process. And they also give you direction while you're working on improvement and provide valuable information about the true value of the changes that we make to the processes. So we've gone over the 5 major guidelines for data collection, and with these basic foundations in place, collecting and reporting data is bound to be cleaner and easier and smarter for all of our organizations. There's a couple of points that I want to make to reiterate some of these previous guidelines. We can be incredibly good at collecting data and yet so incredibly poor at sharing it. What's the point in collecting data if we don't know what comes out of it? How many of your hospitals consistently display information about their recent improvement initiatives or about the quality reporting standards that we're faced with? And what exactly do those staff members do or feel about that information that's reported? Do they feel like they own that data? Do they feel like they can do something about it if a metric is performing poorly? Those are good questions to see whether or not we have appropriate data ownership in our facilities. If we are, actively working harder towards improving various initiatives in the hospitals and sharing that responsibility amongst the whole team, not just one person, not just the manager, but everyone who is involved in those processes. Again, for what purpose are we collecting the data if not to push ourselves to improve some more? I always like Aristotle's quote, "Excellence is not one act, it is a habit." It emphasizes the importance of not only collecting data on a regular basis so that we're staying true to our mission of quality care, but it also stresses the importance of doing something with the data, making improvements to our workplace and to our processes based off of the results that we're getting off of this data. And here's an interesting tip, and it's a little bit of a sneak peek into what Lean can do to help with data improvement specifically, but also in general when it comes to processes. Whether or not you have data that's required by a reporting organization, or if you have a supporting metric to help monitor the progress of those regulated metrics, or if it's just even a data metric that your individual hospitals have asked departments to follow as part of their quality committee requirements. We really need to check in from time to time to ensure that metrics are still useful to our organization and to our patients, or also that the benchmarks that we're setting ourselves towards or we want to achieve are still ambitious enough for us. So are we still measuring for the sake of improving, or are we just measuring for the sake of monitoring, not really anything left to measure? I was at a hospital, a critical access hospital, and they had invited me to sit in on their quality meeting, just to give me an idea of how well their quality program was doing and how they were involving every department in the quality improvement discussion. This quality meeting lasted about 2.5 to 3 hours, and it was a 1-hour scheduled meeting. And essentially, they had department by department report on metrics that they were assigned to measure, and several of those departments just reported on the fact that they were 100% compliance on this particular metric that was 100% for the last 3 years. It really didn't add any value to the meeting, but also it really added no value to that department manager who showed up literally to just report that, yes, yet again, we are 100% compliance, and it's always been that way for the last 3 years. And you could tell that the morale in the room was sinking lower and lower as we got longer and longer into the meeting. We really need to see whether or not our metrics, of course, are stable and consistent, but we also need to make sure that our metrics are still useful to us, that we're measuring it for a good reason. And so a lean tool that is incredibly helpful here is called 5S. 5S is a great, simple lean tool that helps to achieve workplace organization, and is free advice because you certainly can look it up online and be able to introduce your organizations to 5S. It's a great starter tool to really get a feel for what lean is about in the healthcare industry. It stays true to the lean concept of retaining value and eliminating or minimizing waste, and that technique just really allows us to analyze our process, maybe our workstation, or in this case, our book of data metrics, to see what really needs to stay, what's truly useful to us, and what needs to go. It's kind of lost its meaning to our organization. 5S is literally based off of 5 steps that all start with the letter S, and it starts with sorting. You first organize and you look at the items that you have and whether or not there are things that you haven't used in years, or those that you absolutely need to use every day, every minute of your day. And so you kind of really start to segregate between those that you can kind of discard versus those that you need to keep. Once you discard all the items that you really don't need, you go to the second step, which is straighten. So then you kind of look at all of the items that you have deemed is necessary to your processes, and you figure out where you need to place it. There's always a location, a perfect place to put these items. That might mean maybe a highly common supply that is used in the supply room that you're going to put in the center shelf where everyone can access it. This could also mean for us in data that you're working with your HIT vendor to make sure that the data metrics that we're trying to pull are still it's easily accessible. The third step is shine, which is more about cleanliness and making sure that you're keeping the items that you have deemed necessary and valuable to the process, keeping it clean and tidy on a daily basis, and making a habit of keeping those front and center to your day. And then the last two kind of blend in together, standardize and sustain. It's really about making sure that you're maintaining the first three principles, that you're constantly vigilant about making sure that we continue to keep the most valuable metrics in front of us, or that maybe something that has gone out of use, it's less important to our organization because we certainly have standardized it, and so we need to take it off our books. And sustaining it. That goes back to Aristotle's quote, and making sure that we make a habit of keeping our workplace organized. On the simplest example that I can always come up with is if you were to walk into your closet and look at the clothes that you didn't wear for the last 2 years, although you swore that you were going to take out those bell bottoms at some point and wear them, and really look at what clothing items that you really just don't need, what items that work well because it's the fashion, it's what you do day to day, you're going to work and you need all of your business clothes items all the time, and then trying to straighten it out, kind of sorting inside your closet, where the clothes should go, that are most commonly used every day, making sure that you have your shoes that you need the most right in front of you, easily accessible, and maybe those leather pumps that you don't use as often, they're tucked up in the corner above you on the shelf. That's really kind of a good way to simplify what 5S is really about as you sort and straighten. The same thing can happen here in data. As we look at the various data metrics, I think it's clear that nationally they do the same thing, whether it's through the National Quality Forum or through CMS. There are metrics that come on the board and come off the board because they are also realizing that there are metrics that nationally we're doing pretty well with, and I think that we can continue to assume that people are going to be measuring it probably a little bit less frequently than before, but it's become a new standard, and everyone knows that these processes need to be in place, and so we can take this metric off the books because it's no longer of use to us to track whether or not we're improving or not. We're all doing pretty well. Same thing should happen in our hospital organizations. How many data metrics are we looking at across the board, whether or not they're required by various reporting agencies, or even if it's basic metrics from department to department that's important to our business and clinical processes. Are they still telling us useful information as we report on it, or are we saying that we've been 100% compliance for the last 3 years and we'll continue to report 100% compliance because the process has never changed. It's standardized. We know how to do it. There's no worries about it. Really think about 5S'ing your book of data. Just to visually give you an idea of what 5S means, at least on the physical front, the first set of photos is actually a supply closet from an orthopedic department. They had tons of things in there, including some old signs warning patients about construction that was completed at that time 5 years prior, that they still held on to. And so they did a 5S process to really look at what exactly they really needed, what they could junk, and then straightened everything out, put things above head level because they weren't as commonly used, and put the ones that were more commonly used more at eye level so that everyone could spot them more easily. It's always good for workplace organization of any sort, so if you're curious about doing this after the call, you can do it to your own desk as well and start to think about, what exactly is most important to you as you do your day-to-day work. The computer obviously is going to be the biggest item that you need to keep in a easily accessible place, but how many folders do you have that are stacked up that you haven't touched in the last year and a half? And do you need to use the articles that you saved up over the last 10 years but you haven't touched? Maybe it's time to officially archive and retire them. So data collection is the backbone of Lean, so that we can get to the fun part, which is improvement, process improvement using Lean. Understanding the 5 principles of Lean will help to apply them in the most effective way, because honestly, Lean there's a misconception about Lean and the fact that it's a set of problem-solving tools. It really isn't. It is based on a foundation of principles designated to not only quantify and eliminate waste, but to also help hospitals change the way that they do business for the better. And data is interwoven into all of the principles and the tools that are associated with Lean. When it comes to value, which is determined from our patient's point of view, how do we measure whether or not we're achieving value for our patients? There's a way that we can measure that. Value stream mapping, which is the process steps or the sequence that a product or service goes through a hospital. How long does it take for a lab that is drawn in the ED to be processed that day? The value stream mapping. There's a data metric that can be associated with that as well. Eliminating waste. Waste is very, very important when it comes to Lean, and there's actually 7 specific types of waste that have been identified in Lean that we can eliminate from a process, and we can also measure that as well. How much excess time did we have spent dedicated to re-sterilizing an instrument because it missed part of the process? There's waste that we can measure through that. Percent compliance or number of defects. How can we measure waste in that respect? There's also flow, which is a major principle of Lean, which is to make sure that we're allowing the products, the services, and especially for data too, the information to flow smoothly through the hospital without delay or disruption, and we can certainly measure that. And lastly, when it comes to Lean, we're constantly striving for perfection, and this goes back to our employees and our frontline folks, and the fact that when they really start to embrace Lean and that culture of process improvement all the time, they never stop trying to improve the value provided to their customers. There is no finish line when it comes to Lean, and it's certainly a never-ending elimination of waste. It is committed to total patient satisfaction, total commitment to quality, and total employee involvement. But Lean functions best when we have our foundations for data collection and data analysis firmly in place. So with that, I am going to wrap up here on how Lean data quality can make quality reporting for your facilities easier, as I have these final thoughts to summarize where you can help your hospitals. The 5 major steps of data collection that can lead to useful information and decision making. We certainly need to be clarifying those data collection goals, developing operational definitions and procedures, planning for consistency and stability of actually doing the data collection, and then continuing to improve our measurement, but also our process consistency. Luckily for us, when it comes to quality reporting, the first two guidelines typically are for the most part decided for us, but that doesn't mean that P4P or CDC or CMS is going to help us do our data collection for us from the ground up. There is still movement that needs to occur before we can feed the CMS abstraction tool, right? So these 5 guidelines will help to make sure that we're not only collecting data consistently and accurately, but that we're also analyzing this data to get good, useful information, which leads me to bullet number 2. Good data collection can be ruined by bad data analysis. Please definitely check in with your hospitals and see how exactly they're taking the data that they can get off of their EMR systems or off of their paper chart audits, if we still have those. And how exactly are they analyzing them? Are they still looking at it, numbers on a chart and trying to figure out if there's a trend from that? Maybe they're looking at bar charts that are inappropriately sized. The frequency is incorrect. We're looking at it on an annual basis or maybe on a quarterly basis, and it's not specific enough for us to really see if there are changes occurring for better or for worse. So really start to look at how we're visualizing data, how we're analyzing that data to help us make good decisions. Data doesn't belong to just one person. It belongs to everyone involved in the process it measures. Data stewardship is becoming a key priority in our industry. And until we make data transparent and make frontline staff owners of their daily processes and the data associated with it, it is difficult and pointless to expect our staff to feel empowered and to feel excited about process improvement and the data reporting that goes with it. Put it in front of them. Make them feel like they have ownership of it, that they can do something about it if something were going badly. I teach the model for improvement, which is widely used by the Institute for Healthcare Improvement. And the second question in that model speaks directly to the importance of data in relation to improvement activity. The question being, how do we know that a change is an improvement? It goes hand in hand. We measure data because we want to improve something off of it. And so we really need to think about how we can make sure that the data is not just being collected for the sake of being collected. We're actually doing something with it. We can use it to see what the changes were as we implant a newly redesigned process. What were the metrics telling us before we changed it, and what are they telling us now that we've done it? Does the cabbage mortality rate go up, or does it actually go down after we implemented a new process? Okay. And a useful metric today can become a useless metric tomorrow. I like to emphasize that little sneak peek with the 5S. I always encourage hospitals to think through all the data that they are collecting, or regulatory or not, and do a quick 5S on them. Are we still as useful as we were 2 years ago? Am I receiving useful information from the data collection on this metric? Or sometimes it's just about the benchmarks themselves. Are we getting a little too relaxed on our goals, on our benchmarks? Have we consistently met our